Welcome, everyone. We'll just wait a few minutes for everyone to join. Good morning, good evening, good afternoon. Welcome once again to today's EPIWIN webinar. Today, we will be having the webinar on the clinical management and IPC guidelines for management of mpox. This is the launch of the new updated guideline, and we have a very exciting line of speakers today for you. I hope it will be useful and interesting for you. I'm Supriya Besbara. I lead on EPIWIN. Before I hand over to our technical team, I'd like to announce some of the regular announcements. The first is that we'd love to hear from you. Those of you who are familiar with EPIWIN already know this. So please introduce yourself on the chat. Tell us what you do, where you come from. We'd love to hear from you. During the webinar, when you have questions, please put your questions in the Q&A, not in the chat. That's how we can keep track of your questions. But if you have any insights or anything you'd like to share with us of your experience, please then put it in the chat and we will look at it for sure. This webinar is being recorded and the recordings will be shared on our EPIWIN website, and it will also be shared with all those of you who have registered by email. The presentations will also be shared if the presenter gives permission. So you will have access to this webinar in future as well. To start with, I'd like to welcome Dr. Nedret Emiroglu, who's the Director of ECC in WHO's Health Emergencies Program and the Director of this department. So welcome, Nedret. I'd like to invite you to provide the opening remarks for the launch of these new guidelines. Over to Nedret.
Thank you very much, Supriya, and good morning, good afternoon, good evening to all of you who are joining us now, yet another EPIWIN webinar on an extremely important subject and a significant milestone. So we are launching now the WHO's Living Guidelines on mpox. As you will hear now more, Olivier, about the epidemiology of mpox, the most recent situation. However, you should be aware that it is still both endemic and also affecting new regions and new countries, and also addressing the most vulnerable communities with some common unique features, and also the disease is crossing the borders. And the Emergency Committee on International Health Regulations met last week, and they have agreed to that the situation has to be continued as a public health emergency of international concern, which is a reminder that the threat remains real, dynamic, and in need of coordinated and evidence-based actions. Of course, one of the critical elements in managing mpox is the clinical management and the infection prevention control measures. And this is exactly one of the major systems as defined in the WHO's health emergency preparedness and response strategy. Safe and scalable care is one of the, as I was mentioning, the important elements. And as was mentioning, it's not only the treatment, but it depends on clear, actionable standards for clinical care, infection prevention and control, and of course, washed water and sanitation and hygiene, all delivered within this safe and scalable care function and infrastructure with the capabilities available in the countries. And these new guidelines contribute directly to the goal by focusing on evidence-based clinical care and the RCC measures that can be implemented across a wide range of settings, including during outbreaks and humanitarian emergencies. So you will hear from some of the internal WHO experts in this area, but also I'm really happy to see the globally well-known external respected experts from various platforms, including the IPC Guideline Development Group, the Africa CDC, and I'm sure the information and experience knowledge they share is going to be important. And another element I would like to say, what do we mean by living guidelines? So these are not the documents we prepare and put on the shelves. They are not static. They are living documents, which means that we continuously review the science, we continuously review the evidence, and updating them as needed as new evidence and information becomes available. So it ensures that these guidelines are relevant, responsive, and grounded in the latest science. And I'm happy that today you will have the opportunity to hear directly from the experts. But also I would encourage you, please use the opportunity to raise your questions, your situation, your experience, knowledge, so that we could also learn from you. Thank you very much. And is it back to you, Supriya, or to Olivier?
Yes.
Back
Thank
to
you.
Thank you very much.
Thank
Thank you very much, Nadred. So thank you for giving that overview and introducing the launch of the guidelines. Before we go into the guidelines for IPC and for the clinical management, I'd like to invite Dr. Olivia Le Pen to give an overview of the EPI overview of the situation. So over to Olivia, who's the unit head for EAR, which is Epidemiology and Analytics for Response in the World Health Organization's Health Emergency Program. Over to you.
Thank you, Supriya. Good morning, good afternoon, good evening, everyone. And I'll try to give you an overview of the epidemiology in the next 5 minutes. So if you could put the slides up. Are the slides up? Yes, next slide, please. So this is an overview of the current monthly reports of mpox globally. On the right-hand side, what you can see is that the overwhelming majority of cases currently being reported and over the last year are coming from the African region. But you can also see on the left-hand side, and I've seen many people joining from various parts of the world, there is mpox being reported in all WHO regions. and mostly of clade 2B. You may remember the large clade 2B outbreak, particularly affecting men who have sex with men in 2022 and 23. Next slide. In terms of clade and clade distribution, this map becomes increasingly complex, but just to remind everyone that we've got different clades of mpox. The yellow background is a clade 2B in the large global outbreak that we had a couple of years back, and that is still going on at low levels. And then if you zoom in on to the African region, you see in green and in blue clade 1A and clade 1B. And really that is what also led to the public health emergency of international concern, the new clade 1B that started in the South Kivu region in DRC and then spread to a number of neighboring countries and continues to expand to some extent geographically, but also with exported cases, as you can see from the stripes maps in a number of countries. Next slide. Zooming in now on Central and Eastern Africa, clade 1A was historically endemic in the sort of central parts of the DRC, largely driven by zoonotic spillover event and some element of human-to-human transmission. And clade 1, and that's in red here, and then clade 1B in blue has emerged in the eastern part of the DRC and then expanded to neighboring countries. And I'll speak a little bit about the trends in those neighboring countries that have reported the most number of cases. You can see that there's co-circulation of clades as well in a number of provinces, including in Kinshasa, where clade 1A and B is present and spreading within the same types of network. Next slide. So looking at the DRC in particular, looking at the national picture is not very helpful because of the different dynamics in the different clades. But so if you look at the provinces that were mostly affected by clade 1B, and namely South and North Kivu, what you can see is that there's a somewhat decrease in trends since late November, which is now stabilizing. That is also illustrated on the graph on the right-hand side. I don't really have time to delve into the detail, but what you need to remember from this slide is that what we seem to be seeing in the DRC is either plateauing of trends or decreasing in trends in a number of provinces. We're not seeing right now really an increase in transmission in the DRC. Next slide. In Burundi, we've seen sustained declines after an initial outbreak that spread fast, particularly in urban setting, Bujumbura and Gitega, and mostly adult population. And you see that both geographically and in terms of cases reported, it's been decreasing over time, and it's been now sustained at far fewer cases than we had at the peak at the end of October, early November. Next slide. Somewhat similar trajectories are being seen in Uganda, with a bit of caveat in how we interpret trends because testing has reduced over the last few weeks. But nevertheless, if you look at Kampala, that's a classic mpox epidemic trajectory in an urban setting with initially fast growth, a lot of transmission, particularly among adult population groups, and then now a decline with some also level of transmission in some other parts. Next slide, please. Just draw your attention to the age, age and sex distribution of reported cases and how it's changed actually very little over the last few months. Maybe a few things here. If you look at Uganda and DRC, this is an epidemic that is largely driven by adults and young adults, largely through sexual contact in high-risk groups. In Burundi, likewise, it's been driven mostly by young adults, but also you can see small, young children under 5 that are believed to be more at the receiving end of transmission within households when adults become sick first. But in South Kivu, you see an age and sex pyramid which has changed now, and with more, actually proportionally more children and young adults as well being affected. And that's probably important in the context of a clinical case management seminar as well, to think that in some parts you still have a lot of children who may also present with different types of complications and presentation. South Kivu used to have an age and sex pyramid similar to what we've seen in Kinshasa or Uganda. On the back of a decreasing epidemic, we see that the dynamics and the epidemiology is somewhat changing. Next slide. Just to highlight that Sierra Leone is not a clade 1, is a clade 2B, and has had experienced recently over the last few weeks a really large epidemic, which appeared to be now going down, but has seen one of the highest growth rates we've seen in the African region, not too dissimilar from what we saw in the global 2B outbreak, and affecting also mostly young adults. Next slide. And I'll finish with this. And I'm slightly over 5 minutes. I'm at 6 minutes, so I'm going to try to finish within the next minute. But just as this is a seminar focused on clinical case management, I thought it'd be important to just look at mortality and severity and what we can tell from the epidemiology. So this is essentially an illustration by age group of the case fatality ratio for a number of places. Uganda, North and South Kivu, where you see the CFR is actually very low and not really this difference by age. The highest CFR and the highest mortality has always been reported from endemic areas in DRC. It's a mortality that we don't really understand well because it's much higher than elsewhere. It's also syndromic mostly in its report. So most of those cases are not confirmed and so could also be other things. But whether there's this link to particular vulnerabilities, co-infection and others, I think there's still more work there. But when we look at 1B in general and more globally, the risk factors are not too dissimilar from what we've seen in the global 2B outbreak, and it's mostly immunodeficiency and immunosuppression. And the most prevalent, particularly in young adults in that part of the world, is HIV. And we see that most severe cases and deaths are among people who are with uncontrolled HIV or unaware of the HIV stages and being diagnosed with HIV upon diagnosis with mpox. And we see that as a main risk factor for mpox severity and mortality. To some extent, perhaps also malnutrition, and there's early work suggesting that malnutrition is associated to some extent, again, probably reflecting a level of immune vulnerability. Next slide. And this is just the same type of information, but just comparing clades and region. And essentially what you can see here is, with the exception of clade 1A, and for the reasons I just described as well, that it needs to be better understood. What we've seen elsewhere is that the case fatality ratio for mpox is actually surprisingly similar across most regions, generally reasonably low, below 0.5%, but not negligible, and some people with particular comorbidities and vulnerabilities will develop severe disease or die from it, whereas many others will have a fairly mild infection. And I'm going to stop here with 7 minutes and hand it back to the next speaker. Thanks so much.
Thank you very much. Thank you for that overview of the EPI situation and for doing it in 7 minutes. Well done. As you know, these guidelines have 2 parts to it, the infection prevention and control and WASH element, and the clinical management part. So for the first part, I would like to now invite April Boller, who's the team lead for IPC, to give an overview, and also after that to introduce and invite the 2 other speakers for IPC to talk about that. So I'm handing this section over to you, April.
Great, thank you so much, Supriya, and excellent overview, Dr. Olivier. So I'm Dr. April Baller. Let's move to the next slide, and really I'm going to very briefly just speak a little bit to why these guidelines are being published now, how they're being published, what are they saying, and then just briefly to introduce some of the key products from the IPC side. So what are the triggers for these new guidelines? The first guidance that was produced back in 22 were very good, and however, they were called interim rapid response guidance, and they were based on a scoping review. Since then, there has been a vast increase in availability of clinical and epidemiological data, which Dr. Olivier just spoke to, and there's also more expertise and understanding and experience with respect to case management. There has been the emergence of a new clade. There are changes in transmission patterns, and importantly, the quality of care. There are justifications now for improving that through some of the evidence that has been provided. And at the same time, ensuring that we keep our health workers and other patients safe while patients are receiving care for mpox. Next slide. So how is this process actually, how did it happen? So first of all, the WHO commissioned an update of a systematic review on IPC measures to reduce mpox transmission based on a publication by Cohen back in 2022. The Cohen publications, which you can see here on the right, looked at all data up until September 2022 and was looking at the modes of transmission. So the new systematic review, which is still under publication, it hasn't been published yet, but it looked at all data from September 2022 into September 2024, and was asking some key questions about IPC. They was not able to actually respond to each of the questions because evidence wasn't there. And so in the end, they looked at the modes of transmission. And this is what has informed the IPC guidelines. The key results and findings from that review was importantly that over 95% of all transmission occurred by a direct physical contact, both sexual and non-sexual. There have been no confirmed cases of inhaled-based transmission that were reported in the review, and only one case of droplet exposure. Most of the healthcare workers who were infected, which were rare, was through needle stick injuries. So the second step for the process was the WHO convened a multidisciplinary guideline development group, which is composed of experts from infectious disease, IPC, clinical care, public health, HIV, pediatrics, and maternal health. So these experts met and used the grade and evidence to decision-making framework, which really is about taking the evidence and from the systematic reviews and using them to formulate the statements. Now, the statements can either be recommendations or good practice statements. So this is the process. If we go to the next slide, you now see actually what the new guidelines are about. So first of all, they do build on the 2022. They integrate IPC and clinical aspects. So we think this is very important for the frontline health worker. They make 7 new recommendations and 2 good practice statements across clinical and IPC. And they address for IPC measures within the health facility and within home-based care. And for clinical management, they look at the initiation and continuation of antiretroviral therapy for those that are co-infected with HIV and breastfeeding. As far as how these guidelines can be used, they can be used as standalone, or they can be adopted and adapted into national guidelines. And as Dr. Nedrit spoke about in the beginning, these are living guidelines, which means that they are will be updated as soon as evidence is available and new recommendations are made. Next slide. So finally, just briefly to speak about some of the products that we have, and that's thanks to the guideline development group and also to the IPC experts we have within the public health emergency network. There's a vast amount here, and they're focusing in 3 areas. They're focusing in the area of safe and scalable care in the context of healthcare facilities. And the one we'd like to highlight here is the rapid assessment tool, which is basically looking at IPC and WASH measures within health facilities and assessing if they're being met or not. So that's in your top left. And then we also have within community protection, a recently released hand hygiene call for action, emphasizing the importance of hand hygiene to mitigate and to control transmission. And then finally, the clinical management guidelines, which Dr. Toshi will speak to. And just one more I wanted to mention in the top right, the new strategy for mpox and IPC, for IPC and WASH in the context of mpox has been published in just a few days ago. And that is very helpful also for countries as they're developing or updating their national plans. So with that, I would now like to hand over to Dr. Toshi Okwar, who is the chair of the IPC guideline group, and she will walk us through the actual guidelines and recommendations. So thank you, Dr. Toshi, over to you.
Thank you, April. Next slide, please. So I'll provide the highlights of the new infection prevention and control recommendations. Next slide. We start by showing what the guidelines show for healthcare setting recommendations. In healthcare settings, in patients with suspected or confirmed mpox, WHO suggests that health and care workers should use contact and droplet precautions. And contact precautions they include personal protective equipment, gloves, and excuse me, the personal protective equipment, the gloves, and the sorry, I'm struggling here. Give me 1 minute. Let me drink water. Okay. Then also consider using a respirator, a special face mask to filter particles when the ventilation is poor or unknown, or when a risk assessment indicates that it is needed. And such conditions will include when there's immunocompromised status or in the presence of mucosal lesions. And airborne precautions should be implemented if varicella zoster virus, that is chickenpox, or measles are suspected, and should be continued until they are excluded. And the airborne precautions should also be implemented when performing aerosol generating procedures. And if single rooms are not available or there's a limited supply, cohorting can be employed. Can cohort confirmed patients and prioritize single rooms for the suspected and probable patients. Next slide, please. Here we see the implementation considerations in healthcare settings. When taking care and isolating patients with mpox, hand hygiene should be performed in line with the 5 moments, WHO 5 moments for hand hygiene. And for the patient placement, we have mentioned that we need to isolate the patients in the room where we can provide contact and droplet precautions. And the use of the personal protective equipment. For contact and droplet precautions, we should use the following PPE: gown, gloves, medical mask, and eye protection based upon a risk assessment, and consider a respirator instead of a medical mask if risk assessment has been described before. And then for injection safety, we have to follow standard precautions for safe injections and sharp injury prevention. And it's important to avoid the use of sharp instruments for specimen collection. Lesions should be swabbed, and we should follow the WHO guidance for diagnostic testing for mpox. For environmental cleaning and disinfection of mpox care patient areas, it should be done at least twice daily, and immediately the surface should be disinfected. But when we have high-touch surfaces, for toilets, latrines, and showers, there should be more frequent cleaning, and disinfection should also be performed. For handling and transportation of linen, the recommendation also makes provision on how to handle the linen to ensure that it does not transfer or contaminate the patient environment. And waste management. Waste management should be handled in a way that we treat body fluid and solid wastes coming from mpox patients as infectious waste. And waste should be segregated according to WHO according to standard precautions. General waste should be separated from infectious waste and sharps and placed in appropriate bins at the point of use, and should also be disposed of terminally following the appropriate guidance. Next slide, please. Then for the guidelines for supporting patient interaction with visitors, it is recommended that measures should be put in place to support patient interaction with family and visitors to promote well-being. However, visitors or caregivers should perform appropriate hand hygiene before and after entering or leaving the patient room, and they also have to be closely supervised and taught how to use personal protective equipment properly. For vulnerable and high-risk individuals, they should be counseled to make an important and informed decision on whether to visit the patient or not. And alternative modes of communication, such as video conference, video calls, can be offered to patient relations to interact with patients. Next slide, please. We now move over to the community settings. There are IPC measures to mitigate and control mpox transmission in community settings. Hand hygiene communities should be encouraged to apply hand hygiene regularly. And for patients that are being taken care of at home, we'll get to that recommendation, there should be dedicated personal items. Care should be taken in handling the linen and the laundry of such patients, and environmental cleaning and disinfection, as well as waste management, should be handled properly. We'll get to that in the subsequent slides. Next slide, please. For the home-based care considerations, the IPC guideline provides that there has to be engagement with community care workers and volunteers, and accessible instructions for infection prevention and control should be made. People who will isolate at home or be taken care of at home have to be provided information in a clear way that allows them to understand instructions on how to employ the infection prevention and control practices at home. Environmental cleaning and waste disposal should be promoted, and the vulnerable groups have to be supported. There also has to be monitoring and follow-up through community health workers. And the home-based care should happen in collaboration and with the support of risk communication and community engagement. There has to be constant risk communication and community engagement to ensure that communities know what to do to avoid spread of mpox in the communities. Next slide, please. Next slide. For the home-based care recommendation in community settings, WHO suggests that persons with mild, uncomplicated mpox lesions cared for at home are not required to isolate. And isolation means the separation of infected people with a contagious disease from people who are not infected. But this has to be provided their lesions are covered and they wear a well-fitted medical mask when in close proximity with others until all lesions are healed. And persons with mpox who cannot cover lesions or who are unable to wear or tolerate a medical mask should isolate at home. And IPC measures to reduce environmental contamination at home should be implemented. Next slide. The home care implementation considerations that are provided for in the guidelines include how to use mask and lesion covering. So mpox patients who are being cared for at home should always wear a medical mask whenever they are near others. And if a medical mask is not available, a fabric mask can be considered. No, a fabric mask if a medical mask, a medical mask if a fabric mask is unavailable. The lesion should always be covered whenever they're in close proximity with others, with clothing or bandages when they're around people. And the use of telemedicine or phone can be used for remote checkups. And as much as possible, no in-person visits. In the aspect of hygiene and environment, cleaning and disinfection of all personal spaces and frequently touched surfaces should be done. Patients who have mpox and are being cared for at home should, as much as possible, limit leaving the home. However, if they have to leave their homes, it is recommended that they wear a mask and cover all the lesions and use a private transport, and such private transportation should be well ventilated. And if they are getting to the health facility should be informed ahead of time so that they can anticipate the visit of the mpox of such an individual. For self-care and support, persons with mpox should manage their care or designate a healthy caregiver. And such a healthy caregiver should be somebody who preferably is vaccinated or has previously had mpox and recovered from it. And caregivers should keep 1 meter distance. However, when closer contact is required, such as when cleaning or doing laundry, they should wear a medical mask and glove and practice strict hand hygiene before and after glove use. Next slide. Thank you. So I hand back to April, I believe. Thank you.
Thank you so much, Dr. Toshi, for that overview. It now has a pleasure to introduce Dr. Andy Bolabola, who is the IPC unit head for Africa CDC. So Andy, over to you.
Thank you, April, and it's a big pleasure for me to be here today and to share some of the challenges we find on the ground. And it's really a pleasure to be speaking after great speakers like Dr. Tochi and yourself. Next slide, please. So for the challenges, you've seen all the practices that have been presented coming from the new guidelines. And today I want to share with you what is really happening on the ground, especially now I'm deployed to the DRC, and I can see firsthand some of these challenges. So there might be really limited access to essential IPC supplies in healthcare settings, and this include respirators and masks, medical masks. But rather, we need to appreciate that medical masks are more accessible when it comes to comparing them to respirators. So we also have a barrier in terms of nonverbal communication and even verbal communication that have been reported while we use any respirators or any medical mask. So the idea behind this is to encourage that the patient can wear a medical mask to limit really transmission via droplets. And of course here, physical distance is also recommended. The same with other IPC standard precautions, including here, lesions should be covered, environmental cleaning should be DORAF as well. Next slide, please. So as you may appreciate, isolation capacity is much reduced when you have huge outbreaks in resource-constrained settings, and you need, as facility or treatment centers, to have more capacity. And that's not the case as we stand in the ground now, and many of these treatment centers are overwhelmed or overcrowded. So what is the solution to this? We bring in the home-based care kind of approach to have some of these patients, given the fact that they may meet the criteria of being mild, so they can be treated at home and receiving care there. But some prerequisites, as that was presented, you have the clinical factors and you have the environmental factors. These are WASH and IPC factors which need to meet the level of practice, meaning the capacity and the performance. So if you don't have these capacities, we need to find a place in the healthcare facilities. But in meantime, we do encourage clinicians and or home-based caregivers to really always look at WASH capacity at home so that we can have these patients being taken care of at community level and reduce the transmission and also the overcrowding in health facilities. That doesn't help to really break the chain of transmission. Next slide, please. So for the home-based care isolation, as I said, it is very important to remind that when you are isolated, you may face some challenges, including mental health challenges. You may feel anxious, you may feel lonely, and sometimes people get depressed, really. And this can also amplify some other problems, including stigma toward infected individuals. So if the patient who is isolated at home really can cover his lesions and can put on a medical mask and, of course, observe some physical contact. Avoid some physical contact. It doesn't need to be isolated, so it can have at least a chance and opportunity to see family members and interact with them, at least verbally, so to limit the contact, the physical and close contact. So that way we will also fix the problem of mental health, but also keep in mind that we need to still break the chain of transmission for mpox virus and cut down and curb the curve for this outbreak. I think this is the last slide. Thank you, and back to you, April.
Well, thank you so much, Dr. Andy or Prof. Andy, for that overview and very important points. So with that, in the interest of time, we will skip the IPC Q&A part and we'll add it on to the Q&A at the end. So it's my great pleasure to hand over to Dr. Jamie Rylance, who will walk us through the clinical management component. Thanks to you, Jamie.
Thanks, April, and hello to all colleagues. It's my pleasure to introduce two speakers who took a great part in forming the clinical part of this guidelines. I should point out that, as April has, the interim guidelines from previously have multiple different practical informations and other recommendations. And what we're presenting today are new guidance. And Dr. Diaz may talk at the end about where we go from now, including new guidelines on top. So you'll see some representation of really important topics from this and some which we're still working on because this is a rolling guideline, as Nadret said. But firstly, as you heard from Dr. Olivier, the deaths in Uganda were predominantly associated with HIV and mpox, and that is a very strong risk factor for severe disease. And so it was an absolute pleasure to have Prof. Valdilea Veloso on our guideline development group and also on a special working group on HIV. She is a professor at Fiocruz in Brazil. She's headed multiple national and state HIV programs. She's part of her national guideline committees and multiple scientific executive teams with a specific interest in pre-exposure prophylaxis and HIV. So she's been able to, along with a number of other experts within our GDG, process all of this information to present these recommendations. I'm going to hand over to her now. Then we'll hear from Grace Ndisi, who I will introduce, and we'll have some questions and answers at the end. So please do put your question and answers in the Q&A chat, and we'll try and come to them. But over to you, Prof. Veloso. Thank you.
Good afternoon. In this session, I will summarize the new guidelines recommendation on antiretroviral therapy for people with mpox and HIV. The main WHO guidance is clear. People with mpox who are ART naive or who had a prolonged interruption of ART should start ART rapidly. This is a strong recommendation based on moderate certainty evidence. The slide, please. The main WHO guidance is clear. People with mpox who are ART naive or who had a prolonged interruption of ART should start ART rapidly. This is a strong recommendation based on moderate certainty evidence. Operationally, this means we should offer early HIV testing for anyone with suspected or confirmed mpox. Once HIV is diagnosed, ART should ideally start within 7 days, and same-day initiation should be offered whenever possible. For individuals already on ART and with an undetectable viral load, the recommendation is to continue ART without interruption and to repeat the viral load test if the last result is more than a year old. Next slide, please. Now, why was this recommendation made? There are some concerns about the potential risk of immune reconstitution inflammatory syndrome, or IRIS, which has been reported in people with very low CD4 count. Mpox IRIS refers to the clinical worsening of mpox symptoms after starting ART, likely due to immunorecovery, triggering inflammation against residual viral antigens. Although there is no direct RCT data specific to mpox and HIV, and the certainty of evidence on ART timing in this setting remain very low, the current WHO recommendation for rapid ART initiation is based on high-quality evidence from the broader HIV field. 3 large randomized controlled trials with over 7,400 patients showing that early ART reduces morbidity and mortality in HIV. Observational data suggests that delayed ART in people with mpox and uncontrolled HIV may increase hospitalization risk. A meta-analysis of 5 non-randomized studies with more than 2,000 participants showed a 4-fold higher odds of hospitalization among those with unsuppressed HIV. The panel judged that harms from delay were very likely, including linkage to retention in care and progression of mpox replication. So, in summary, early HIV testing and rapid ART initiation is essential, as well as linkage to care. Thank you.
Thank you, Professor Veloso. Very clear. And I'm sure we're going to come back to you and ask you some practical questions about that linkage to care shortly. I can see some questions coming through. Please keep them coming. And I will also just post the link to the Magic app. This is the online version of our guidelines, so that you can navigate those all through the BMJ website in order to see the recommendations. The Magic app version is online and collapsible, so you can see a little bit more clearly some of the recommendation highlights. So I'm going to come to another of our guideline development group members, Professor Grace Ndisi. She was also part of our special working group on breastfeeding and nutrition, which supported the guideline development group in making these recommendations. She's a pediatrics and child health specialist based at Makerere University in Uganda and at Malago National Referral Hospital. She's a fellow at the Uganda National Academy of Science, and she has a very extensive, broad range of publications in child health, including mpox. So, Prof. Ndisi, over to you, and then we'll come back for some Q&A. Thank you.
Thank you very much, Jamie. I'm going to share, I'm very glad to be here with all of you, and I'm going to share with you the recommendations regarding breastfeeding. So WHO suggests that mothers with mpox should continue breastfeeding whilst limiting direct contact with their non-infected infant until the lesions are fully resolved. Take IPC measures, including limited contact between the mother and infant, except during breastfeeding, and cover active lesions on other parts of the body. The mothers with alveolar lesions should use if one breast is affected, they should use the other breast to feed the baby. The mothers should be informed of the risk of infection and discuss alternative feeding strategies. The context will drive the feasibility, availability, and safety of alternatives to breastfeeding. Whenever it is safe and feasible, expressed breast milk or milk substitutes and no direct mother-infant contact is advised. But we know that in the low resource settings, it may be difficult to consider alternatives.
Prof. Grace, can you try and speak a bit louder? It's not a very good connection. Thank you.
Okay, let me get a bit closer to the microphone. Is that better?
Yes, a little bit. Just speak as loud as you can. Thank you.
Okay. So the next slide. WHO suggests that mothers who recover from mpox infection and who had withheld breastfeeding and direct contact to resume breastfeeding and direct contact with the infant as soon as the lesions are healed. So the mother needs to be supported to continue to express breast milk while not breastfeeding to maximize the likelihood of reinitiating breastfeeding once she has recovered, and in order to avoid complications, for example, cystitis. Next slide. WHO recommendations on postnatal care of the mother and the newborn. So undernutrition is associated with 45% of child mortality. We all know that, that's a fact, especially in low-income countries. So WHO and UNICEF recommend early initiation of breastfeeding within 1 hour of birth. We know that as a universal recommendation. Exclusive breastfeeding for 6 months, which is also a universal recommendation, and then continue breastfeeding up to 2 years of age or beyond. So the mpox recommendation aligns with this recommendation, although mothers with mpox will have an increased risk of infecting the infant or child. So good nutrition is essentially important in these vulnerable populations. So safe temporary alternatives to breastfeeding can be used only where feasible. So the recommendations do not change. The mothers will continue to breastfeed, including initiating breastfeeding in the first 1 hour and continuing to breastfeed the babies, but try to limit as much contact with the baby as possible in order not to infect the baby. Next slide.
Thank you very much. Thank you very much, Prof. Grace.
Thank you. Thank you for your attention.
Again, really clear, and thank you for being part of our development group and also for the presentation. We have some minutes now for Q&As, and I will want to come back to Prof. Veloso, Prof. Ndizi, and also Dr. Toshio Cho to ask around the theme of linkage to care, because it seems clear as we evolve through this pandemic and the needs of patients become very obviously aligned with what the health system needs to provide. The linkage to care is key. So I'm going to ask, if you would please, Prof. Veloso, how you think patients' linkage to care can be best affected, and the problems that might pose. And I'm going to ask the same question then to the other two panelists. So over to you, Dr. Veloso. How can we increase this linkage to care?
Yeah, one important point is that when you say refer to care, to linkage the patient to care, it's important to foresee that not necessarily patient will get an immediate appointment. And so we need to be very careful and when possible, to right away start the antiretroviral therapy and provide a supply that needs to last until patient get an appointment in the CSC. One important point also regarding to care and linked to care is that patients that are very severely immunosuppressed may have other opportunistic infection. And we need to be aware of this risk and to, if necessary, to screen for other infections that are common in patients with very severe immunosuppression. but always try to be available for patients regarding their needs and to guarantee that patient arrive at the service that will take care of the HIV care.
Thank you very much. So I'm going to ask also Prof. Grace to comment on that. And if you could, Prof, we then have a couple of extra questions for you about pediatrics, but over to you for linkage to care, and that might include nutrition as well. How do we integrate these services best?
Much, Jamie. I know linkage to care. I will give an example where I work in Uganda. We have different levels of health care. The level 1, which is the community health worker, level 2, low-level health facility, level 3, level 4, and level 5. And then the level 4 and 5, level 3, 4, and 5, these are district hospitals. And level 5, these are either regional referral or national referral hospitals. So, giving examples of the first few patients, the referral was very complex. Only one facility was allowed to care for these patients, the Entebbe, which is a regional referral hospital. But still, patients would go anywhere where it is close to where they reside. So, right from the community health worker, the low-level health facility, the middle level, and the referral centers, every person, a health worker, should be able to know what to do. Where should the patient go? Those who are critically ill, and the ones who are not critically ill, what should be done? So I don't know whether I'm answering the question, but I know linkage to care can be a bit complex. A patient can come from home directly to a regional level hospital or even to a referral hospital. So the referral system is not so straightforward when it comes to a patient, but every level must have guidelines, must know what to do. Regarding nutrition, the malnourished children, the adults who are malnourished, we know they are immunocompromised, so they have a higher risk of getting severe mpox. So these ones should be considered to be seen by somebody who is specialized, even if they have mild disease. That's my view.
Thank you very much. That's clear from both of you that we need to know where we are referring and have the capacity to screen and to test and treat for HIV, but also for malnutrition. Thanks to both of you. Dr. Grace, can I bring two questions to you from the chat? One is about, is HIV applicable to children, HIV recommendation applicable to children with clade 1B? And maybe Dr. Grace and then Dr. Veloso on that. We'll see if we have other questions.
Thank you, Jamie. The guidelines for initiating antiretroviral therapy, they apply both to children and adults. So there would be no reason to hesitate initiation of therapy. But of course, when somebody has severe disease, or when somebody has mild disease, we have also seen cases where mpox can manifest as immune reconstitution syndrome or immune reconstitution pathology. So these are patients, if they have to initiate therapy, the recommendations should be used, but there should be an attempt to ensure that there is regular follow-up.
Thank you. Prof. Veloso, I don't know whether you have anything to add else on clades and HIV?
Yeah, this is this is important to identify HIV infection and to treat it in order to contribute to improve the immunity, and so patient will be in a better condition to overcome mpox infection.
Thank you very much. I'm just going to come to Dr. Tochi to ask a question from the chat. It was an ask for further explanation of the rationale for not isolating individuals during home-based care. And I wonder whether you would like to go into that in more detail. So why is non-isolation a possibility when patients are being cared for at home? Over to you, Dr. Toshi.
Thank you. So when April was presenting, she had presented the process that we took in arriving at that. So about 200 studies were looked at with thousands of patients. And the main thing that came out was the very, very close contact, both sexual and non-sexual, but largely sexual contact was the main mode of transmission. And then when we then looked at the values and preferences, and along those lines, it became clear that when patients isolate at home, when we weighed the values and the preferences, and we weighed how we came out on the other side that it was better if they don't isolate at home. If they're cared for at home, they don't necessarily have to isolate, as long as those conditions were met. It's not everybody that can be catered for at home, but if people are at home and then can meet the implementation guidelines that were put there, the group came up with a recommendation that the data we are seeing points to that they can actually be at home and not isolate.
Thanks very much. That's very clear. So I'm going to request that we close this part of the Q&A.
Jamie, can I add
Sorry,
something
Grace.
to that?
Yes,
Questions
sorry.
about breastfeeding, and then can mpox not be transmitted through breast milk? Well, there are neonatal cases recorded. Yes, there are neonatal cases have been reported, and they actually tend to get severe disease. And then transmission through breastfeeding studies are ongoing, but it is possible, it's potential, because we also get maternal child transmission. Then also, when the two breasts are both affected, what should this mother do? We didn't put that in the guidelines. Also, when the baby, because we have seen where the baby is affected by contacts from other people, the mother doesn't test positive. But when the two breasts are both affected, the mother can actually express the breast milk. Somebody said, can she use a pump? Yes, she can. And she has to also ensure that she's using very hygienic measures to prevent contact between the breast milk that she has expressed and the infected area around the nipple. So that's a possibility.
Thank you, Dr. Grace. I think April Baller wanted to come in, and then we'll close. Thank you, April.
Thank you so much, Jamie. No, it's just to complement what Dr. Toshi said around the home-based care without isolation, in the context that the main mode of transmission is through contact, close contact. And so the interventions that are being put in place are really barrier methods. And that is why we're focusing on covering the lesions and using the medical mask. Of course, if the patient cannot cover the lesions, then they should not use this option. And just another point to emphasize is, due to the shedding of the virus in the environment, it's very critical not only to do the hand hygiene, but to do frequent cleaning of the surfaces. And that includes in particular around the bathroom and handles. Thank you, Jamie, and back to you.
Thanks. I think there are a lot of more questions, and many of them are within the guidelines referred to. So I hope you'll take the chance to look through those carefully. And there are a number of other practical considerations which the guideline development group put down within the guidelines. So with thanks to our panelists, thanks to Prof. Valadea Veloso, to Prof. Grace Ndizi, and to Dr. Toshi Okwor, I'm going to move on to put in place and in your screens the next slide to show you there are a number of other associated products with this guideline. I don't know whether you can show the next slide, please. And we can provide more specific resources in the context of having posters for healthcare workers, for job aids, and a number of other webinars which were on the previous 2 slides. We will share these slides with you, but for now, for the purposes of time, I'm going to hand over to Dr. Janet Diaz, the unit lead for safe and scalable care at WHO in the emergencies program. Dr. Janet, please.
Hi, everyone. Thank you for that outstanding webinar show presentations, and thanks so much to the colleagues that presented today. I'm not going to cover the main points because I think everything was clearly described by the presenters, and it is kind of short in the sense that these recommendations that we've described are high-level recommendations. We've used a lot the great terminology, which is the methods that we do to develop recommendations, but a lot of this is around the practical implementation of this, and we did not go into too much detail around that. But those questions are important, and we do hope to continue with webinar series that are practical in their nature, with a little bit more opportunities for questions and answers. And this is a journey that we're doing together to optimize the clinical care, to optimize infection prevention and control interventions and WASH interventions. So the slide that I don't see, but hopefully is on your computer, is a slide around the next steps and how we are going to continue to optimize our interventions for patients to best care for patients with mpox safely. So we already started that process. Some of you may know or may have been involved in our meeting that just happened earlier this month in Nairobi. And this was focused on the clinical supportive care, optimizing supportive care interventions. So first off, that meeting focused on things around more details on how to care for skin, not cover the skin, but care for the skin lesions, how to care for skin-related complications, how to care for eye-related complications, and also the use of antibiotics in uncomplicated skin lesions and in complicated skin lesions. So a lot of more detailed discussion happened at that meeting to improve our recommendations in these areas, and I expect that this next updated guideline may come within 3 months. As well, the work is also ongoing in infection prevention and control and WASH, and some best practice statements are also under development. Finally, after our meeting that happened earlier this month, and from the discussions that you heard today, right, the uncertainties around us needing to develop recommendations with very low certainty evidence and using indirect evidence to inform, and that is fine. We do the best we can, but that means more evidence or more direct evidence needs to be generated. So there are some global collaborations that have been kicked off since that meeting, and I want to describe a few. One is the characterization of mpox-related complications in pregnancy and newborns. We do know from the case series of multiple case series, and also we heard from the experiences of the colleagues in the region about the relatively high rates of maternal complications and congenital complications. So we need to describe that better, and we're going to start a regional collaboration on that. We've heard from our colleagues in HIV as well around the timing of ARVs, but we also heard about what about iris. So that information also needs to be collected in a standardized fashion so that we can best understand what those risks are and also improve our practices in that area. And finally, what are the mid and long-term sequelae of mpox? And we've seen from Dr. Olivier, the CFRs being described as low, in most of the areas. But what about the morbidities associated with mpox? And the ones that have been most concerning that we've been hearing about from our colleagues are around vision complications and vision loss in some cases, and those the prevalence of that complication does need to be better estimated, and the care of those patients put into place, as well as the complications from complex skin lesions. So That's one. The second is on the mpox-related eye complications. Because of the increasing, again, information around this complication, there is interest in doing clinical studies around topical antiviral use for this complication, and we'll keep you posted on how that advances. And then finally, on the mpox skin atlas, of course, because of the scale of the outbreak and the countries affected, there has been more collection of images of the rashes, and with that hope that there's been an agreement amongst collaborators to use those images to update the mpox skin atlas to version 2.0. So before I give the floor back to my colleague Supriya and EPIWIN, it is my joy to say thank you. So. And I always try to make sure that we acknowledge all the people that need to be acknowledged. The production of a guideline such as this one is a massive production. It's been something we've been working on for many months, and a lot of work behind the scenes. So one is to thank the guideline development group experts. These are global experts from all parts of the world in the fields of clinical medicine, in the many subspecialties of clinical medicine, the fields of infection prevention and control, and really big thanks. They're all in the guidelines, so you can see who is involved. It's all transparent and out in public, and thanks for their contribution and the collaboration. In addition, I want to thank the technical working groups. There were some additional experts that came into technical working groups in order to develop the guidelines in infection prevention control, the technical working group on breastfeeding, and the technical working group on HIV and ARVs. We also had, without systematic reviews, we cannot develop a grade-based guideline. And we had groups that were involved in their systematic reviews from McMaster University, Yao Gao and Kwiki Hao, from the Liverpool School of Tropical Medicine, Kerry Duan, and then also from the Infection Prevention and Control Department, King Abdulaziz Medical City Hospital in Saudi Arabia, under the supervision of Dr. Majid Al-Shamrani and his team. So thanks to them for helping us get here. Thanks to our co-chairs, Toshi Okwar and Tom Fletcher, who couldn't be on with us today. And thanks to the technical teams here within WHO. So again, so a big acknowledgement to the speakers you've already heard today, from April Baylor, but also thanks to Vicky Willett, who's not with us today, Nosheen Usman, who's here in the room, to Jamie Rylance, Marta Lado, who was also our consultant, not here in the room, Tanya Kelly, and then also on behalf, I wanted to give a thanks to the other departments that contributed to this guideline, specifically Remco Peters from HIV program and Wilson Ware from Maternal, Child and Aging. So with that, thanks so much for joining us, and we look forward to seeing you again soon. Over to you, Supriya.
Thank you very much, Janet. Amazing work, and as you can see, this continues. So watch the space, I hope. I'd like to thank Janet, actually, for her support to EPIWIN and for leading all of this. And last but definitely not least, our director, Nedret Emiroglu, for her guidance and leadership in this work. I'd also like to thank, from the EPIWIN perspective, everyone who's worked behind the scenes to make this happen. Firstly, Michael, who's sitting right next to me. He's done all the background logistical work on setting everything up. I'd like to thank my colleagues in Project ECHO, Sanka Mitra particularly, and Connie, who've supported us through this webinar. I'd also like to thank our IT team and our interpreters for all the background work and for interpreting this and making it more accessible to many more people. And you're part of the EPIWIN family. We hope, as you know, we have an EPIWIN almost every week now, and we hope you will join us next week. And Michael has sent the link for next week's EPIWIN in the chat, and we look forward to seeing you again. And with that, Nedret, would you like to say a few words before we end?
Just echoing the thanks to all who have contributed, including very hardworking WHO teams. And thanks for joining us, and see you next week.
Thank you. Bye.
Thank you. Bye.